Hello. Hi there, everyone. My name is Dr. Omar Bey, and this is OBHealthy. And we are a group of physicians of Physicians Health Network that's here for several reasons. And the number one reason is that we would like to improve the health of people of African descent. The second reason that we're here at this webinar every second Saturday is that we want to encourage young Black males to get into medicine, to become a doctor, because you can do it. We're here to mentor, we're here to encourage, we're here to let them know that they're welcome in this field. Love to have you. Also, let's just kick back and because we have an exciting show today. What we're going to do is we're going to have each physician just pick a topic and let's just talk about it for a moment. And you, the audience, if you have a question or if you have a comment, please type it in. Let us know that you have that comment, and we want to answer. We want to discuss. We want to help you through all your medical problems. Connect with us. Let us know what you're thinking out there. All right. As you see, the doctors are coming in, and what we'll do is we'll continue to let them come in. I want to thank OBHealthy for allowing us to bring this webinar to you each and every month. And remember, it's the second Saturday of each month at 1 o'clock, and please let friends and family know. The most important thing that I can say today, understand, please do not change any aspect of your medical care until you consult your. Only your doctor can truly take care of you medically. All right. So let me think if I'm thinking of, just want to make sure I cover everything before we get started. As far as subscribing to our YouTube, understand that you can go to OBHealthy's website. Just scroll to the bottom and hit the YouTube sign. Our complete channel will come up and all of our past webinars will. Please do this, check them out. You know, they're there for you. And that is serious medical education going on there. So, and we're excited to be here. We're excited to be here with this new year. All right, let's get started. First thing I would like to do, and the first thing we always do, is let each physician introduce themselves, and understanding as the program goes on, as the webinar goes on, more physicians will be joining. Dr. Atherley, can you start us off, please?
Of course I can. Good afternoon, everyone. My name is Trevor Atherley. I'm an interventional cardiologist. I practice in Essex County, and I'm based predominantly at Newark Beth Israel Medical Center. Thank you. Good to be here.
All righty. Dr. Jordan Garrison.
Good afternoon, everyone. My name is Jordan Garrison. I am a board-certified general surgeon specializing in bariatric surgery and venous diseases and disorders. They have an office in Florham Park, New Jersey, as well as Hackensack, New Jersey.
All right, thank you. Dr. Robert Cunningham, welcome.
Thank you. Good afternoon, everyone. I'm Dr. Bob Cunningham, East Orange, New Jersey, practice general ophthalmology, comprehensive ophthalmology, same thing. Heavy emphasis on glaucoma. We are here to serve our people and take care of what needs be. We're based in a few different hospitals in the area. Glad to be here.
Thank you, Bob. Dr. Kevin Clark.
Hey, good afternoon. Dr. Kevin Clark. I'm a surgical oncologist. I work at Newark Beth Israel. Glad to be here.
All righty. And Dr. James Court, please.
Good afternoon. I'm Dr. James Court. My practice is located in East Orange, New Jersey, internal medicine, and I'm a classmate of Dr. Cunningham.
All right. And I'm Dr. Omar Bey, and I'm a pulmonary critical care physician with a subspecialty in nutrition. And I am overwhelmed that these fine physicians, oh boy, these physicians are coming together with me to pull this webinar together so that we can educate our people as far as health is concerned. Dr. Atherley, I'm going to ask you to start off the topic that you've chosen and just share with us what you think about that topic, and so that we can get going as far as the audience is concerned and the physicians if they have any questions as well. Thank you.
Well, thank you. Just to start the ball rolling, I'm prepared to discuss any aspect of cardiology, but I thought I would mention one of the most prevalent of cardiac diseases, and that is heart attacks. I think it's important that our general audience should recognize the signs, symptoms, the underlying pathology and causes of heart attacks, and be able to help individuals, either themselves or others whom they recognize, having heart attacks. To give you an idea of how often this occurs, about 800,000 people in this country will have a heart attack this year. And every 40 seconds or so, someone has a heart attack. But this is not necessarily the immediate cause of death. Death from the whole variety of cardiovascular diseases, diseases including heart attack and other aspects of the cardiac and vascular system, death from these will occur about once every 33 seconds. So in the interim, while I've been speaking to you, we've lost at least 2 people who've died of cardiovascular diseases. So what's a heart attack? Essentially, a heart attack is death of the heart muscle. And there are a variety of situations in which this can occur. Let me first of all enlighten. I'm sure I have a very enlightened audience anyway, but I can just reiterate some aspects of the actual anatomy and physiology, the function and structure of the heart. The heart is a muscular pump. And contrary to a lot of popular opinion, it is the most powerful pump that we have in our body. Yes, the heart works incessantly, as you all know. And in doing so, the heart requires a lot of blood. You see, while the heart's job is to pump blood throughout the entire body, the heart itself has a significant need for blood, moment to moment. And this need is met by the coronary arteries. These are small arteries which run on the surface of the heart, and then they give small branches which burrow into the muscle itself and provide the muscle with blood. Now, these are susceptible to some diseases, the most common of which is atherosclerosis, or hardening of these arteries, and narrowing of these may be caused by cholesterol or the fatty substances being deposited into walls of these arteries. So they may gradually narrow, and while doing so can give rise to symptoms of chest pain called angina. But the most critical of the problems that can occur is if there's a rupture of one of these little plaques, one of the little areas of formation where there's been cholesterol deposited, rupture of these, releasing substances into the bloodstream would trigger off blood clotting, so that a clot suddenly forms in the artery, which previously was freely allowing blood to flow from distal or from higher up areas down to the very ends of that artery. So if the block occurs, it suddenly shuts off blood. Depending upon where the clot occurs, the amount of blood loss, the amount of muscle deprived of blood may vary significantly, from a large area to a small area, giving rise to a large heart attack or a smaller heart attack. We diagnose these heart attacks on the basis of a number of findings, objective findings, which we can employ. However, from the point of view of the patient himself or herself, you should be aware of some of the common symptoms that may tell you that you or someone near you, a family member or a friend or a colleague, may be having a heart attack. The most important and the commonest that we all recognize is chest pain. Now, this is not just any old pain. It tends to be a severe chest pain located in the center of the chest, not as often on the left side as is predominantly felt, but in the center of the chest. Now, it may radiate to the left side, the left shoulder, down the left arm, sometimes to the right shoulder, right arm, sometimes up to the neck or to the head. The pain may even radiate down towards the abdomen or the belly, as low as the belly button. However, it doesn't go down to the leg. Many patients will tell me that I had this heart attack where I was having pain in the left arm, chest, and it went down to my left leg, are likely to be mistaken. It does not go that far down. But this severe chest pain or pressure may be accompanied by several other features. Oftentimes, patients experience what we call diaphoresis, that's a cold sweat, suddenly break out for no other reason in a rapid, profuse perspiration. There may be nausea, even vomiting. Patients may have an overwhelming feel of tiredness and shortness of breath. These symptoms may vary depending upon the individual. And we know that there are certain groups of individuals in whom these uncharacteristic or slightly different manifestations may be seen more frequently. In the elderly and in women, the atypical or different features are seen more frequently. And so you have to be aware of this strange feeling of nausea, of breaking out in a cold sweat, sometimes vomiting, faint feelings, palpitations, feeling the heart fluttering. Even in the absence of chest pain, these may be of significance. Now, when the heart attack is suspected, not necessarily recognized initially, but when suspected, then the onus is on you, the sufferer or a bystander, to try to get help as soon as possible. Because there are many things that we can do nowadays which are time related in saving the patient's life and the damage to the heart muscle. You see, the totality of the muscle damage is not instantaneous. The heart attack appears to be instantaneous, but there's a gradual increasing amount of heart muscle which dies over a period of time. And in many instances, we have hours to limit the amount of muscle that is lost. So time is muscle. The quicker you get the patient to get elaborate treatment, then the less damage may occur to the heart muscle. So what do? You recognize the possibility and you suspect myocardial infarction or heart attack, then you advise the individual to chew an aspirin. It can be a 81 milligram aspirin or baby aspirin, but chew an aspirin and then swallow it. You seek help and get to an emergency room as soon as possible. Now, if the individual is in fact suffering from a heart attack, there are several signs and symptoms that we, the physicians, then will use in our diagnosis. The symptoms I've mentioned to you, and the signs may be related to those symptoms, but we do several objective measures. One of the most commonly used initially is an electrocardiogram, EKG or ECG, as you may call it. And this shows certain changes in particular aspects of the EKG, which suggests to us that damage is occurring. Damage is evolving, and that we must act quickly. In addition to that, we take the usual vital signs of the patient. We may do x-rays. We take blood tests. Some of these blood tests reflect enzymes or chemicals which are released from the damaged heart, and which are therefore elevated in the blood levels. But we don't always wait for these results to occur. We may have to make a very abrupt and quick clinical decisions and decide that if there's enough evidence to suggest that there's a blockage in progress and the muscle is being damaged, that we immediately take care of this by some forms of treatment. Now, in addition to the aspirin, we can give medications which help to dissolve away clots, which help prevent platelets or some of the components of the blood clot from clumping together. We give blood thinners which can loosen or prevent the coagulation or the formation of that clot. We give these kind of medications. We give medications, we call them beta blockers, but these are essentially medications which can prevent the heart from having to work too hard, because the harder the heart is working, the more blood it needs. So we can do that. We can give medications to help ease the pain of the patient. We give cholesterol medications. There are lots of things that we can immediately start in the patient. But what importantly limits the progress of this blockage and the manifestations of heart damage is getting rid of that clot that's blocking the blood and restoring the blood supply. Now, previously, this would be done by giving certain chemicals called thrombolytics. You don't have to worry about the terminology, but these would dissolve away that clot. Nowadays, what we do is get the patients to an appropriate cardiac catheterization laboratory, and we pass tubes into the body to look at and to treat those clots. What do I do when this happens? Is that I take the patient to the cardiac catheterization laboratory and pass a tiny tube through either the artery at the wrist, called the radial, or the artery in the upper groin area, upper leg groin area, and these all lead back towards the heart. So I pass this tube back towards the heart, and through the tube, I can inject dye. This radio-opaque dye shows up on x-rays, so that with the x-ray machine over the patient, I can look to see how well the blood is flowing and see if there are blockages preventing the blood from flowing. If you do see a blockage, and the commonest thing we'd see in the major kind of heart attack, what we call an ST elevation, a SEMI, but you don't have to worry again about that. But in the most major kind of heart attack, we often see a total blockage of a portion of the artery. We can then surmise that this is the culprit. This is the location of insufficiency of blood to the muscle, and it's that deficit of blood which is causing the heart attack. So we spring into action and we pass a tiny tube, a wire, in fact, all the way through the artery, back to the heart, back to the arteries that run on the surface of the heart. And over that, we thread a small tube, which contains a balloon and a stent. What we then do is blow the balloon up, which squashes that blocked, it's oftentimes fairly soft, that blocked, soft, newly formed clot. And it reopens the tube in your own body, your coronary artery, through which the blood should flow. So one moment we see no blood flowing, next minute we squash that blockage which is developed there and allow restoration of blood to the artery. In order to safeguard that the tube remains open, and many times we place what is called a stent. That's a small wire mesh. It looks like, those of you who still remember the old ballpoint pens, it looks like a little spring that you see in the ballpoint pen, a little wire mesh. And under high pressure, several atmospheres of pressure, we forcibly squeeze that into the wall, the inner lining of the artery, so as to act as a scaffold and keep the artery open. So now what do we have? We have blood which has been restored beyond the blockage to the more distant parts of that heart muscle, relieving the insufficiency that was occurring. We have an artery which has been stabilized with that stent. And we have indeed, at this point, limited the extent of damage of the heart muscle to the patient. So that is the most important new method of treating coronary artery blockages which occur in the setting of a heart attack as it is evolving. Hopefully, over the succeeding days to weeks and months after that, medications and appropriate preventative measures will be taken, which can help to prevent other heart attacks. Because, you know, there are risk factors, there are factors which can predispose any individual to having a heart attack. And so it is important that we not only give medication for the heart attack directly, but that we continue in the future to try to prevent the development of further blockages and other heart attacks. Remember, the worst risk factor for having a heart attack is having had one previously. So anyone who's had a heart attack is at greater danger of having a second one. There are some identified risk factors, and I suppose we could go into those at another time, but I'll just mention very briefly certain identified risk factors which can predispose anyone to having a heart attack. Certainly age is a factor. We look at the age of 55, which is not necessarily old, but older than that, higher risk than those younger. We are, in fact, just parenthetically, we are seeing larger groups of young individuals who are having heart attacks nowadays than we did identify before. So age, sex, males tend to have heart attacks at an earlier stage than females, who are somewhat protected until after the menopause. Then they catch up rapidly with males in terms of heart attacks. And hereditary factors. Unfortunately, if you've got a strong family history, that is, if other members of your family, mother, father, siblings, etc., have had heart attacks at young ages, then unfortunately you're predisposed to this, and therefore you should take specific risks to curtail these risk factors. You should take the opportunity to limit those that we can limit and prevent heart attacks from occurring. The ones that we can have an influence on are diabetes or blood sugar, high blood sugars, control your sugar, high blood pressure, a rather major cause of, or one of the etiologies or one that contributes to the causation of heart attacks, high cholesterol, especially the bad cholesterol. There are several kinds of cholesterol. We identified predominantly the HDL or the good cholesterol and the LDL, the bad one. The bad cholesterol or LDL leads that cholesterol to be deposited into the coronary arteries. The good cholesterol removes it and takes it to be excreted by the body or denatured. So we like to have a good amount of the good cholesterol and a low amount of the bad cholesterol. These can always be identified by your treating physician with the appropriate blood test performed. So cigarette smoking is the worst of the habits which can cause you to have heart attacks. And there's no good excuse for cigarette smoking, especially anyone who has had a heart attack before. You know, the Surgeon General, one of the Surgeon Generals in the past has once said that cigarettes are the only substance sold legally in this country which can cause death. So we should beware of cigarette smoking. And I see many of my patients who smoke very heavily and who wonder whether it's too late to stop smoking, especially if they've had some of the ravages or damages from heart disease, heart attacks. And I always inform them of the significant improvement on cessation of smoking. If you're a smoker and you stop smoking for 1 year, you diminish at the end of that 1 year by 50% your chance of having a heart attack. So stop immediately. The sooner, the better. And after 10 years, maybe 10 to 15 years, some people consider, if you stop smoking for 10 to 15 years, it's as though you never smoked. You have not had an interim heart attack during that waiting period, then your risks are significantly diminished to those, in fact, of a non-smoker. Exercise or lack thereof is an important factor. And I recommend healthy heart exercise at appropriate intervals, 3 times a week at least, and aerobic type exercises. Obesity, being grossly overweight, and here Dr. Bay can help us with some of the nutritional aspects of this, but patients whose body mass index is defined by the relationship of the height to the weight. If it is significantly elevated, the body mass index or BMI, then you may be considered at higher risk for heart attacks, coronary artery blockages, etc. So there are a lot of things that you can do in the immediacy of a heart attack, and there are many things that you can do before or after heart attack to try to prevent heart attacks from occurring. Importantly, you should follow up with your physician at the intervals as determined by him. You should control those risk factors that you can and try to live a healthy life free of further heart attacks. I'm open to other questions at some point in time, but I'd rather give the opportunity to some of my erstwhile colleagues to deliberate and mention to us some things that are of interest to them. Thank you.
Excellent.
I want to ask a quick
Excellent.
question.
All right. Hold on. We got a lot going on here. Dr. Ali has joined us. I would like the 2 doctors that have joined us, Dr. Patrick Anderson and Dr. Ali. Dr. Ali, can you turn your mic on and can you introduce yourself, please?
Hi, good afternoon, everybody. My name is Dr. Mazhar Ali. I'm a gastroenterologist, and I practice on the West Coast in San Diego, California.
All righty, thank you. And Dr. Patrick Anderson, he must be, I know he's muted right now. Let's get Patrick in a moment.
Hi.
Dr. Jordan Garrison, I know your hand was up first. Let's get this, because I think this is going to turn into a cardiac session. That was excellent, Dr. Garrison, go ahead.
Now, a large portion of the country was watching Monday Night Football, and the young man got hit in the chest, fell out. Could you tell us, 1, what happened, and 2, what was going on in the hospital for the 7 days that he was in the hospital? What were the consequences of that incident?
All right. That's a very important question. It's been asked over and over. I was not subject to a lot of the questioning because I was actually out of the country at the time this happened, but I did see the news. First of all, I'm not at liberty to discuss the medical specifics of that individual.
Right.
But let me use a for instance and give you what I think could have happened to an individual under such circumstances. The one thing that comes to mind is a problem that we call commotio cordis, a very rare occurrence. How does this occur and what does it mean? Well, we've identified this for several decades now, and it occurs when after a blow, trauma to the chest, specifically over the heart area, when this trauma is delivered at a specific point in the cycle of the heart contraction, that it may trigger off rapid and irregular beating called ventricular fibrillation. Let me mention that this has been reported in many different sports, but mostly where there's an object, and the object could be as a hockey puck, it could be a baseball, which seems to be the one sport which has more of these episodes occurring. It could be a cricket ball for Dr. Court, who's an avid cricket player still, and a cricket expert. And we've had a few episodes of commotio cordis recorded in cricket, but it's the delivery of a mechanical injury to a small focal area of the chest wall at a specific time. Now, if you think of the cardiac cycle, and we say, well, we've got 60 to 70 beats a minute. That means every second there's a heartbeat. During the course of that heartbeat, which is stimulated by electrical activity, and again, I suppose I have to take a little time to mention how that occurs. The heart, as I mentioned, is a muscle, but the muscle doesn't beat just on its own. The muscle is stimulated by electrical impulses, starting from the upper areas of the heart and gradually progressing down to the lower areas. And this proper and orderly flow of electrical activity gives rise to synchronized and proper contraction, first of the upper chambers, the atria, and then the lower chambers, the ventricles. Those are the powerful pumping chambers. So this is what we rely on for every single beat, proper and orderly electrical activity. Now there's a particular phase of the cycle where the electrical activity passes actively to cause the muscle to contract. And then there's a passive form where it is restored. Chemical interactions occur which restore those cells back to receive the next impulse coming down. Now, there's a particular phase, just about 2% of this impulse, maybe 10 to 20 second period, perhaps 10 to 20 millisecond period, during which the heart is especially vulnerable. And so if a blow is delivered during that specific phase, if there's a high intensity delivered over the chest wall, and the mechanical energy is transmitted to the heart at that particularly vulnerable time, then it causes the heart to beat erratically. And when the heart beats erratically in this manner, it no longer contracts properly and pushes blood in a properly synchronized manner throughout the body. It's like a bag of worms just erratically quivering. When this happens, then patients suffer the consequences of lack of blood flow to the brain and to other vital organs. They fall, they become unconscious, etc. Now, this is invariably fatal if not corrected. Therefore, it behoves us, if we recognize any such episode, whether on the athletic field or otherwise, to be able to appropriately resuscitate the patient. Nowadays, simple resuscitation by compressions at a rapid rate of the chest wall may suffice until we are able to obtain a defibrillator. Defibrillators are now kept at most sports fields, perhaps in most schools, most athletic fields, etc. This can be used to shock the patient's heart and restore a proper rhythm. I did not see the episode with this particular individual, but I suspect from the descriptions that I received that he received that in tackling the receiver, the tackle actually may have collided with the elbow of the person he was tackling, received a focal point injury to a very specific part of the chest wall. It happened to occur within that 10 to 20 millisecond period, 10 to 20 milliseconds of vulnerability, and it triggered off ventricular fibrillation. The ventricular fibrillation was appropriately gotten rid of by the provision of a shock from a defibrillator, I'm told. However, during the interim, when the patient was not receiving enough blood to the brain, he may have suffered transient, hopefully not permanent damage as a consequence of the impairment of the supply to the brain. And as far as I know, he is recovering well. Again, I can't go into specifics with this individual, but the lengthier the period of deprivation of blood to vital organs, the less chance of full recovery. So the onus is quickly restore the blood flow. And I think this was done fairly appropriately in this individual. Your question about the length of time, again, I can't answer to that individual, but it may have been because they thought there was neurologic damage and had to observe and do various things to try to see how his brain function would improve. We also sometimes do what is, I don't want to get into those details, but chilling of the individual by lowering the body temperature. That sometimes helps in restoration of the patient's brain function. Now, I don't want us to go away with the feeling that this commotio cordis occurs frequently, perhaps less than 2% of the sudden cardiac deaths that occur in athletes, or that it is the most common cause of collapse of athletes. We've had numerous instances of athletes collapsing on the field. I know some of you remember a basketball player, I think he was with Boston, who fell during a game. And there are many others. I can remember a very famous, one of the top scorers in basketball, who played his entire basketball career without any major injury. And afterwards, in a pickup game, he died. A postmortem showed that he was born with a very unusual abnormality of his coronary arteries. These are the kind of things that we look at: coronary artery abnormalities, abnormalities of the muscle of the heart. There's a one that is seen sometimes in athletes, IHSS or hypertrophic cardiomyopathy. Again, you don't have to work with the specifics, but it's a disease of the heart muscle. Things that can cause sudden death in young athletes, maybe disease involving the muscle, disease involving the valves of the heart, and of course, electrical abnormalities. Some abnormalities which may be evident on the electrocardiograms, which are done on these individuals and which may allow us to predict the potential for these sorts of sudden cardiac arrests. Parenthetically, I suppose I can add that a few years ago, I was invited down, I went down to Jamaica because they'd had two athletes who had died. They were athletes, but not necessarily dying on the field. And athletic pursuits are very, very important in that country, and they do extremely well, as you all know. Well, I went down and we, with a team, we evaluated several students, high school students, who were on their athletic teams. And in fact, well, I don't know what the ultimate outcome was, but we certainly identified a very small number of people, at least one of whom comes to mind, who was a good athlete, but we identified that he had the potential for serious consequences if he pursued too vigorously athletic sports, and unfortunately may have had to be withdrawn from the team and pursue less exertional activity, less strenuous activity. Again, I had no opportunity to follow up lengthily, and I've not heard of any sudden deaths of athletes in the last few years in that country. But there are many, many causes, and again, commotio cordis is one of the rarer of the ones. And I dare say you probably will not hear of another one for a very long time.
Excellent, excellent. After Kevin, yeah, Dr. Clark, the vision was, your pictures were switching around there for me. You had a question. Oh, your mic, Kevin.
I was saying it's always good to listen to Dr. Atherley, actually. The question I had, I think you answered to some degree. I was going to ask, what are some causes? We know what some of the risk factors are for a heart attack that you've elucidated and told us about. But in a seemingly healthy person, you kind of answered some of this. What are some of the things that would cause a heart attack? So somebody who is, it doesn't necessarily have to be an athlete, but don't have any of those risk factors that we know about: smoking, obesity,
Yes.
high blood pressure, or cholesterol. What are other things that you would look at that may cause a seemingly healthy person to have a heart attack?
Well, that's an excellent question. And I'm glad that you phrased it with the terminology seemingly healthy, because a lot of patients who apparently are healthy may have significant underlying disease not known. And I think I gave two examples of that. There happened to be athletes who had severe heart disease and not known. In the early 1970s, there's a football player who, seemingly healthy, seemingly in good shape, was jogging back to join the huddle, and he collapsed. In fact, I think that was the only instance I can recall of an athlete, a footballer, who died on the field. He was not able to be resuscitated back in the early 70s. And a postmortem showed that he had severe heart disease like an old man. Totally unknown. He had blockages of the arteries, of the coronary arteries, with the hardening, the atherosclerotic changes that I mentioned can occur in others, in older patients. He had that. So seemingly healthy may be deceptive, and people may appear to be well and have significant underlying disease. Most times when I see heart attacks, I still see the common causes that we've mentioned, those that we can help and those that we can't. Of course, you mentioned the hereditary age factors, sex factors. You mentioned the cholesterol, high blood pressure, cigarette smoking, diabetes, lack of activity, obesity. Those are some of the ones that are a little more overt, but sometimes these are not overt, and you're right. We come across rare instances. You may not be able to diagnose that the patient has congenital, or that is diseases that they're born with, some abnormality of the arteries that they're born with that you never know. I had a patient referred from Barbados this time, athlete, 18 years old. After running a marathon, he collapsed, went to the emergency room, They thought there was nothing much. He mainly had symptoms in his abdomen. They thought it was gastritis or something. He went away, came back to the emergency room, and then was documented to have a major heart attack. He was later flown up, and when I evaluated his heart, we found that he was born with anomalous coronary arteries, or that is, the artery, one artery, a very important one, was coming off from the wrong place and was subject to be squeezed under portion of the heart. It was squeezed and diminished the blood from going to certain areas, especially occurring in his case with high exertional activity. Unfortunately, we couldn't help too much at that stage. That was many years ago. But he suffered the consequences of a heart attack. So there are many things, and answer your question, many things that we may not be able to see, but we always look for the obvious. We look for the underlying significant factors that we know can cause heart attacks. And if not, then we look a little harder for some of the obscure things that we may find.
All righty. You know, well, I'm going to officially make this a cardiac MR because this
Not
is
at
so
all.
good. We can't stop, Doc. You stepped in it now. Dr. Patrick, and we have a couple questions that we will get to. Understand, as far as the audience is concerned, we will get to your questions, Dr. Patrick Anderson. But as the physicians, you know, we're going to ask our questions as well. And I think this is so important as far as our hearts are concerned and the health of our hearts. Dr. Anderson, go ahead, please.
Can you guys hear me?
Yeah.
Yes.
Yes, we can.
Glad to be here. So in chronic diseases, we often try to screen and identify who's at risk for specific things. In cancer, certain screening for certain cancers. In diabetes, we have screening for diabetes. In heart disease, is there a protocol for screening seemingly, as Dr. Clark put it, seemingly healthy individual for any specific type of heart disease? And case in point, an individual who 5 years ago has a completely normal electrocardiogram, 5 years later has T waves inversion, and I'll let Dr. Atherley describe what that could mean. And then on evaluation has completely normal coronary. So how would you, it creates a conundrum as to who gets screened, when gets screened, what you get screened for, and how you screen them.
Excellent question. And certainly, you're right, it does provide some difficulty for those of us involved. First of all, if there is a risk, a significant risk of this patient having heart disease, for example, let's look at coronary artery disease or disease blocked arteries, then we may have some clues which we further elaborate upon and do specific screening of such a patient. If, for example, we have a family member who has a very strong family history, father died at an early age, older brother died when he was less than 55 years old, etc. And especially if this patient has symptoms, we may screen them by looking at detailed testing for the risk factors, look at the cholesterol, the breakdown of the cholesterol, obviously do blood sugars, hemoglobin A1C, which is related to diabetes, look at their blood pressures, or even have them check their blood pressures themselves. We check many of those different factors, which might be more obvious. If not present in this individual, especially before allowing him to become involved in very strenuous activity, either competitive or non-competitive, but very strenuous activity for the first time after a long time, we may insist on this patient having a stress test. Now, a stress test allows us to help predict the presence of partially blocked arteries. Now, stress tests are performed in a variety of ways. Let me give you the simplest way and the rationale for it. You see, there's a lot of built-in reserve in the heart, in the coronary blood supply, so that to perform normal, sedentary, general activity, one is able to perform this even if there are blockages which may be considered significant under other circumstances, significant blockages of the coronary arteries. Now, significant blockage of coronary artery is more than 70% obstruction. It is possible for us to be walking around with 50%, 60% obstructions of blockages of these arteries. As you mentioned, these blockages are commonly caused by fat deposition, fat because of the cholesterol, into the arteries of the heart. It's possible to be walking around not to know at all, to have no chest pain. If there are enough risk factors, strong risk factors that suggest to us this possibility, What we can do is perform a stress test. Now, what does the stress test do? The stress test monitors the patient both at rest and then with certain kinds of exercise. What I generally do is exercise on a treadmill, the patient who's fully monitored, the electrocardiogram and the blood pressure machine. And we look for changes in the blood pressure and specific changes on the EKG or electrocardiogram, which occur with exercise and tell us, this patient may have had enough blood at rest or when sitting quietly. But during the course of exercise, the heart is showing us some findings that suggest that there's an insufficiency. The electrocardiogram has several different waves, P, Q, R, S, T, et cetera. But we look at a specific segment called the ST segment. And that segment refers to the restoration of the blood to the, not only of the blood, but of the muscle to receive the next impulse. So we look at it in between impulses and we see, there's some changes on this electrocardiogram which suggest to us that the heart blood supply was impaired. And then if that's the situation, we follow up further. There are a number of ways we can exercise the patient, and short of exercise, because there are many patients who present to us who require such testing, but are unable to exercise adequately. We have other chemical means and pharmacological means that we can utilize to test these patients. Essentially, the essential concept being, we want to stress the heart to see if the heart can be made to work a little harder and see whether the blood supply can concomitantly increase, or if it cannot increase to this supply, to supply the muscle as it should. Some of these changes are manifest on the electrocardiogram, and sometimes some of our patients may have heard of nuclear stress tests. Under those circumstances, we can do tests with the injection of a radionuclide, and under a scanning machine, we can see whether or not there's an indication of the blood properly flowing to the heart muscle. Interpretation of these can again tell us whether or not there are blockages, whether we can suspect blockages, which are preventing or precluding the blood from properly supplying the heart muscle. So we look at the symptoms that the patient may feel, we look at the electrocardiogram, we look at changes in the blood pressure, we look for a falling, not just a rising of the blood pressure, and importantly, we can look at the nuclear perfusion, the way the blood is flowing through these arteries to the heart. So that is, that's one way we can test these patients. Now, who do we test? Oftentimes, as I said, we may test patients who, without a lot of symptoms, may want to engage in more strenuous physical activity than they had been doing before. We might do that as a precaution. There are others who have a multiplicity of risk factors. 3 or more risk factors might lead us into thinking that there's a potential, a strong potential, that this patient could have blockages. So we might do specific tests to see if there are blockages of the arteries. And the common one I mentioned, of course, is a stress test. There are a few others. We can take CAT scans of the heart and see whether the CAT scans actually show us pictures of the arteries and if they're blocked. So partially or otherwise. So these are some of the tests that we can do. Without continuing with too convoluted an answer, I want to go into the second part of the question that Patrick asked, and that was in T-wave changes in an individual who was otherwise felt to be healthy. Well, the T waves, the ST and T waves, they're a particular segment of the electrocardiogram, and they reflect the repolarization or the restoration of the muscle to be prepared for the next impulse coming down. There are many things that can change the contour or the appearance of these. We know what a normal electrocardiogram should look like, and we may see abnormalities, some of which are specific and some of which are not. T-wave changes may be non-specific. By that, I mean that we're not able to specifically state a reason for these. We can't say, they're having a heart attack, et cetera, but sometimes we can. Sometimes you can see T-wave changes in the setting of a heart attack while the heart attack is occurring. We may see them as a reflection of a heart attack which has already occurred. But commonly, we see these in patients who have abnormalities of the muscle and not necessarily a heart attack. There are many diseases or many instances in which the muscle may be affected and leave some imprint, some impression on the electrocardiogram. So if we were to go into the gamut of other diseases of the heart, and then go into muscle diseases, disease of thickness of the muscle, simple high blood pressure. High blood pressure may so thicken the heart muscle that it may cause the electrocardiogram to look a little differently. And we can detect this on the EKGs, and also, if you want to look closely at the muscle, we can take certain pictures. Echocardiograms or ultrasound pictures are commonly utilized to look at the muscle of the heart and to look at the valves. I didn't go into the entire anatomy of the heart, and I suppose I should take a minute just to do that. The heart muscle, not only are there diseases of the blood supply to the heart muscle, but the disease of the muscle itself, called myopathies, or other circumstances in which the muscle secondarily is affected by a variety of diseases. I mentioned a common one, high blood pressure. High blood pressure, in fact, can thicken the heart muscle as the heart pumps powerfully against a higher resistance. And so in high blood pressure, these patients oftentimes have abnormalities of the electrocardiogram. And specifically, I mentioned the T waves and ST segment changes, and sometimes the QRS, which is a major area of the electrocardiogram. Again, we won't go into specific details of this, except to say that these can be shown and picked up on simple electrocardiograms. An echocardiogram can show us the thickness of the muscle and can show the function of the muscle and the valves. An echocardiogram is not the kind of test that you need to be afraid of. An echocardiogram, very simply, is the utilization of an ultrasound machine to bounce waves through the chest wall into the heart and back. These are picked up, relayed on the machine, and displayed as lines and squiggles and etc., little dots and different colors we can see as well. And using that information, we can define a lot about the structure and function of the heart. So yes, these are some other tests that can be done where we find that there's a suspicion or a need to do these.
Oh, excellent. Dr.
Court.
Dr. Clark.
Dr. Court could go ahead on me, actually.
Oh, yeah, Dr. Court then.
Thank you. We all recognize the eloquence of our esteemed professor, Dr. Atherley. Also, he's my cardiologist. But one of the questions that I have in terms of infarct or heart attack, I frequently get EKGs where it's done and it says old infarct. And the surgeons, of course, want patients to be cleared, and I refer them to Dr. Atherley. Can you inform us what is needed from your standpoint in terms of clearing the patients?
Yes. I certainly appreciate that, because so often I'm asked to evaluate patients who have what are considered abnormal EKGs. Now, the EKG machine may have an automatic built-in interpretation, which allows the misinterpretation of some of these abnormalities as old heart attack or old myocardial infarction, because some of these findings are not very specific and they require a lot more detailed evaluation than the automatic EKG machine may pick up. So what we have to do under such circumstances, after taking a careful history and physical examination of the patient, is to determine if there are enough factors that suggest the likelihood that the patient may have had an old heart attack, is to do the nuclear stress tests. If there is a disquieting symptom, for example, to do a nuclear stress test, which can show us not only the coronary arteries, but can suggest to us if there was a previous heart attack. If there was a previous heart attack, as I mentioned, I think much earlier, having a heart attack predisposes one to a higher incidence of second heart attacks. So it is very important to know if the patient's had a heart attack, even if it's an old one, because you may then have to do something to prevent, as aggressively as we can, the occurrence of a second one. So yes, Dr. Kaur, the electrocardiograms very often tell us this patient's had an old heart attack, but it can be misleading because high blood pressure, scars on the heart for a variety of reasons, cardiomyopathies, muscle damage, many of these can give rise to electrocardiographic findings, which may be considered similar to those of previous heart attacks. So then we are asked to look into a little bit more detail to see whether in truth there has been a heart attack.
So the next,
Excellent. Dr. Clark.
so
And
next
then
step,
after you, Kevin, we're going to answer some questions, okay?
okay. This is a quick one, I think. So the next step, you have a positive stress test, and that we can define what positive means. Can you give us an algorithm or an outline as to what the next steps are?
Yes.
Is it medical management? Is it interventional cardiology? Is it an operation?
I think that's again, a very good question, and it relies very heavily on the patient himself and not just the test. So we assess the patient. If the patient is having symptoms, chest pains, which we call angina, these chest pains which we think are related to the insufficiency of the blood supply. Now, not enough to cause a heart attack, but just enough to cause an insufficiency and make the patient aware of the fact that there's not enough blood going to the heart muscle to allow it to do certain functions, exercise, etc. So if the patient has a positive stress test, then we determine if there's need to go further based upon the patient's symptoms. And if the patient's symptoms are significant enough, we may then go on to do a heart catheterization, which is performed in much the same way as I described the one in the course of a heart attack. Of course, there may be much less urgency at this point. So we pass these tubes through the arteries involving the upper portion of the leg or the groin or the wrist. We can pass these tiny tubes back, inject dye, take pictures, and see, in fact, the architecture, the structure of these coronary arteries and see if they're blockages. If they are, there and then, we can decide if there would be amenable to balloon or stenting, balloon angioplasty or stenting. And just to mention again, for those who may not have heard, if there are blockages, either partial or total blockages of the vital organs, vital arteries to the heart muscle, then I can pass a tiny wire, thread this wire all the way back through beyond where the blockages are occurring, and pass a balloon, a tube with a balloon on it, blow the balloon up to several atmospheres of pressure and squash the blockages. Now, in many instances, unlike in the setting of the heart attack, they may be harder and more difficult to get rid of. So we may have to work a little bit harder to get rid of those blockages. In a heart attack, there's usually a fresh thrombus or clot forming in that artery. But in other situations, it may just be the heavy, dense calcification, calcium formed in those. So we do a variety of maneuvers to try to open up those arteries and ultimately leave a stent or a little wire mesh in the area where the blockage was. Those are some things that we can do. But the decision making as to whether or not to proceed with such an aggressive approach depends very much on the patient, on the degree of positivity that we see, on the question as to whether we consider this patient unstable or stable. Someone who's had this kind of chest pain for a long time, who's quite stable, who has only mild positivity on that stress test. Again, we can quantify the severity of the positivity. In such a patient, it might suffice to give medication, help the patient's muscle adapt to less blood flow. Unlike the situation where we consider a much more aggressive approach is required, where the patient, there's evidence of severe blockage and severe effect on the heart's muscle as a consequence of this blockage, then there might be the need to go ahead and do the aggressive approach I mentioned. Now, under some circumstances, at the time of cardiac catheterization, we see such severe blockages that we consider it unwise and we are unable to open these blockages at that time with the balloon and the stenting. And under those circumstances, we send the patient to open heart surgery, where the surgeon will then perform bypasses. A bypass essentially is the creation of a conduit or new road to which the blood can flow. So if there's a blockage midway down an artery, for example, and the blood is not flowing properly, then the surgeon can take this conduit, which is made up of either an artery which he takes away from some part of the chest, the internal mammary artery, or from the leg. We have a double system of arteries in the leg, and we can take one of those. We use it and attach one end of this conduit to the aorta, that large artery through which the blood flows from the immediately leaving the heart. We can attach one end there, and the other end, we can go beyond where the blockage is. So in essence, we are creating a new road through which the blood can flow and get beyond that blockage to other parts of the heart. So sometimes we're called upon, we try to minimize this, don't let my surgical friends know this, but we try to minimize the need to call such individuals in to take care of the blockages. We try to do them ourselves. So that's another alternative. So essentially, once we decide to progress with our testing, it's either medication, a more intensive medical approach, balloon angioplasty and stenting, as I described, or ultimately the open heart surgery performed by the thoracic surgeons.
Excellent, excellent. Dr. Ali, you had a question.
Well, I was curious hearing this, and, for a lot of the viewers that in the audience, I think the first thing we think about is how can I prevent this? And how I want to make sure I want to optimize my health for this never to be the case. And we know there is a power in aspirin. Sir, could you probably comment a little bit on, at what point would we want to consider people starting aspirin with risk factors, with no symptoms? And, what kind? Maybe the baby aspirin, the 325 milligram aspirin, or any other things that we can do besides exercise, diet, that could help in preventing any of these issues?
Ready, thank you.
Yeah.
And Dr. Ali, welcome. I know that this is your second show with us, and we welcome you 110%. And I'm glad that you're comfortable enough to come in with the colleagues and just ask your questions, man. It's a friendly group. Let's rock and roll. Dr. Atherley, go ahead.
Jump right in.
Okay. Firstly, in the acute setting, if a patient's having an acute heart attack, an immediate myocardial infarction or heart attack, where we know that the little components of the blood called the platelets are clumping together and starting to form the blockage in that artery. At that point, you should chew an aspirin. You can take the 81 milligrams, but you can chew that aspirin for immediate effect, faster effect than just swallowing it immediately. So you chew and then swallow. That's one. In the more chronic situation, there is still some controversy. If you have a multiplicity of risk factors, and we've identified the risk factors before, then it might be wise that in addition to your controlling those risk factors, to take an aspirin. But we do not any longer just recommend preventative aspirin therapy in those who do not appear to have those specific risk factors and are not considered at high risk for it. Simply because, and I think Dr. Ali, your field, gastroenterology, yes, simply because we know that we can cause some complications, which may require that we send our patients to you to help us with those. So nowadays, we are a little bit more circumspect in the recommendation of aspirin, unless we have a good enough reason, unless we have reason to suspect either an immediate heart attack or the potential for a heart attack because of the multiplicity of risk factors. There were some studies in the old days, you can know of them, of course, the nurses study, where a large number of people were given randomized to either have aspirin or no aspirin without specific symptoms, just to watch them over the period of years and see whether or not those who had aspirin had fewer heart attacks. And while we thought that initially the data suggested the benefit, we now feel that the benefit is outweighed by the risk in patients who are asymptomatic. So we don't use that routinely. That's certainly an excellent concern.
Just a comment though, there is some, and it's still controversial, but there is some benefit in terms of colorectal cancer prevention with with aspirin. So it's very tricky. You know, it may prevent heart issues. It may cause bleeding if you have an unrecognized ulcer or gastritis, but it also can help prevent the progression of polyps to cancer. So it's a double-edged sword, so to speak, or it can be a double-edged sword.
Right.
This is with
All righty.
low dose aspirin?
Yes, low dose. Baby aspirin, 81 milligrams.
Yes.
Okay.
Yeah, there are some studies
those-
that some of the NSAIDs, even things like Celebrex or celecoxib, that may have some cancer prevention qualities. But you know, this is what's magical about what we're doing, right? We're talking about the heart right now, and what folks need to realize is every organ system needs a blood supply in order to maintain its own well-being. But then, like a nice jazz quartet, there are those 4 organ systems that requires 2 blood supplies, right? One to maintain its own physiology, and unlike the eye that just sends out neurologic impulses, but requires blood to maintain its own physiology. The heart, the kidney, the GI tract, and the lung requires 2 blood supply in order to maintain a normal, healthy existence, right? So the heart has to have a blood supply to maintain its own physiology, but it also needs to have a blood supply to help the body maintain its general physiology, right? Dr. Cunningham pumping blood adequately to the eye. So here's where Dr. Court comes in with the hypertension and the diabetes, right? Because we know those entities affects the microvasculature, right? So the lung has to oxygenate that blood, which sends enough oxygen to the heart. But here's the thing, if the heart doesn't pump the blood adequately to the lung in 2 stages, from a left side to support the lung's own physiology, but from a right side to help the lung perform its own function, then the heart is affected, right? And here comes the GI tract, Dr. Ali. We and Kevin, we often operate on patients who have ischemic bowel, right? They need the blood to maintain their own blood supply, but for us to function on a molecular level, we need to have good nutrition. So we need to have that separate blood supply going through to absorb all the nutrient-dense foods that we eat. So here is that beautiful quartet that makes this beautiful music that's called good health. So you know, that's why we're leaning on Dr. Atherley so much, because the other three organ system that is so essential for basic function requires adequate function of the heart. So to summarize, Dr. Atherley, how are some of those other systemic entities like hypertension, diabetes affect the normal functioning of the heart, just in the manner in which it pumps?
Good question. Some of them increase the work of the heart. For example, in hypertension, the heart is beating against an increased resistance. There's therefore an increased need for oxygenation of the heart muscle. The myocardial oxygen supply is increased. So that may only be an indirect manner in which it affects the heart. We're concerned also high pressures affecting the artery itself, the lining of the artery, especially where there are bends and curves, etc., that may be affected by high blood pressure. You mentioned other diseases, diabetes. Diabetes involves many areas of the body, and the heart is certainly not spared from this. The small vascular, small blood vessels of the heart, as well as the larger arteries, may be adversely affected by high blood pressure sugars and by diabetes as a disease. In fact, it is disconcerting that even though we know that controlling of the diabetes of the blood sugar does improve the overall function of the individual, there are some areas in which the progress of disease in some of the small vasculature may still be unabated. So that is, of course, a concern. The cholesterol itself, how does cholesterol affect the arteries? The cholesterol is the culprit. The LDL, or the bad cholesterol, is deposited under the intima, or the lining of the blood vessels to the heart, the arteries, and that may grow and form what we call a plaque, a large collection of cholesterol under the lining, and the rupture of that is catastrophic in triggering off the immediate clotting of the artery after the platelets, or smaller component of the blood, start clumping together. So the whole cascade of events may follow as a consequence of that cholesterol deposited in the artery wall, and then the artery wall rupturing, and subsequently acute heart attacks occurring. So there are several different mechanisms, many different ways in which these culprits get together and so-called increase the risk of heart attacks, heart damage.
All right, let me do this thank you, Dr. Atherley. Let me do this real quick. Let's take our halftime break just for a second. And what I'd like to do is, let me just go ahead. I'd like each physician just to reintroduce themselves, because there are people that I'm sure who joined us and are not sure exactly what specialties we have associated with the name. So Dr. Atherley, can you start off, and then we'll go through that, and then I'll go through the other.
Thank you. My name is Trevor Atherley. I'm an interventional cardiologist. My practice is mainly in Essex County, in Newark, Beth Israel Medical Center is my base.
All right, thank you. Dr. Kevin Clark, please.
Good afternoon, Dr. Kevin Clark. I'm a surgical oncologist, and I work at Newark Beth Israel.
Dr. James Court.
Internal medicine. My practice is located in East Orange, and I practice mainly at Newark Beth Israel Medical Center with these esteemed guys.
All righty. Dr. Patrick Anderson.
Hi, everyone. I'm Patrick Anderson. I'm a GYN oncologist. I practice primarily out of Newark Beth Israel Medical Center.
All righty. Dr. Mazer Ali.
Hi, I'm Dr. Mazer Ali. I'm a gastroenterologist with Scripps Clinic in San Diego, California.
All right, excellent. And Dr. Bobby Cunningham, welcome. He's a new
right.
one to our group.
Good afternoon.
Bobby, I'm so glad to have you with us. Please tell us who you are.
Thank you. I like joining the big shots. Okay. Dr. Bob Cunningham, East Orange, New Jersey, comprehensive ophthalmologist. We see lots of everyday issues, mainly glaucoma and glasses. Welcome. Great session.
All right, thank you. And I'm Dr. Omar Bey, pulmonary critical care and a subspecialty in nutrition. What I'd like to say is this webinar we have it available and on our website, it's OBHealthy. You can look at all of our past webinars. If you please go on to the YouTube channel, please make sure that you subscribe to the channel so that we can continue to bring these webinars to you via YouTube, number one. The second thing is that the webinar is, we have it every second Saturday of each month at 1 o'clock. Please tell friends and family so that they can join and become educated as far as their medical health as well. Please do not change any aspect of your medical care until you consult your physician, because only your doctor truly can take care of you medically appropriately, okay? And I would like to thank OBHealthy for allowing us to bring this webinar to you. I'm just so thankful for them to offer their services so that we can do this for the community. Thank you. Now, who had their hand up? Someone did. Dr. Court, go ahead.
Dr.
Oh.
Atherley,
Yes, sir.
how does high blood pressure contribute towards the development of heart failure in reference to the other things that can cause it? What part does high blood pressure play?
Oh, okay, your question is contribute to heart failure, not
Yes.
necessarily to heart attacks. Yes.
Heart failure.
Let me first of all tell, I'd like to make the distinction. I'm glad you brought it up. With some of the terminology that we have in regard to the heart. A heart attack is a sudden episode where the deprivation of blood, because of blocked arteries generally, but where the deprivation of blood brings about damage to the heart muscle. And in a heart attack, some of this damage may be irreversible. Now, heart failure, however, may or may not occur as a consequence of the heart attack, or it may occur as a consequence of other etiologies or causes. So heart failure is the inability of the heart to perform its function adequately, which is to pump blood around to the various parts of the body in an appropriate manner. Now, one can also refer to this as a weakened heart. And many times when we talk about heart failure, we're predominantly talking about weakness of the most powerful pumping chamber on the left side, called the left ventricle. So while there are other terminologies and other areas of the heart which may fail, that is the one that we most commonly refer to. Now, in hypertension or high blood pressure, what happens is that the heart is called upon to work a little harder than it should normally. And this increased work may weaken the heart muscle. It first of all may thicken the heart muscle. The heart responds by thickening its muscle, trying to improve the strength to counteract the high pressure against which it has to contract. And then it may become weaker and ultimately become dilated or enlarged. These are all some of the consequences of the high blood pressure on the heart. Now, some of this may be reversible. And certainly when a patient has hypertension or high blood pressure, we should treat this patient with the given parameters of levels that we need to achieve, with the understanding that in treating these patients, we may be preventing several of the complications of hypertension. There are many others, of course, kidney disease and other things that can occur as a consequence of hypertension or high blood pressure. But the question here specifically referred to the heart. And so one of the beneficiaries of better control of high blood pressure is diminishing the occurrence both of heart attacks and of heart failure, congestive heart failure. Nowadays, we can go on and in more elaborate fashion discuss heart failure, where the heart itself appears to be strong enough, its contraction is strong enough, the systolic or active contraction of the heart may be appropriate. But the relaxation phase, as you know, the heart squeezes blood out with contraction, then it relaxes to allow the chambers to fill with blood, and then rhythmically it contracts again to squeeze them out, and then relaxes to allow them to be filled. The relaxation phase may be affected, so-called diastole, and in that instance, that would be affected to such an extent that the heart doesn't fill well enough with blood, and blood may back up on the lungs, and the patient may experience impairment in breathing and impairment of other aspects of the function because of this malfunction of the heart. So hypertension is one of the known culprits for this. Hypertension can cause so-called diastolic heart failure, that is failure of the heart muscle to relax adequately. So yes, it is one of the factors that we must aggressively approach in controlling, because we have clearly defined that there are consequences, there are major consequences of inadequate control of the blood pressure.
Let me do this. Patrick, I know that you have a question, but let me focus on some of the questions that's come in from the audience, and then we'll get back. Don't forget your question though, please. There is a question that came in, and this is concerning the legs. Once or twice a month, I experience a burning, painful sensation like tight rubber bands radiating down my thigh, traveling down to my ankles. Sometimes it's in both legs. The only way to relieve this pain is to walk until it goes away. Many times the pain stops, but it develops and it may develop into cramps in my calves. I know this is more of an internal medicine but maybe surgery can help us out with this. But Dr. Court, do you find that you have lower extremity cramping and pain and that pain going away with walking? Can you help us out?
If it goes away with walking, it suggests claudication. But to me, when you first described this patient, the thing that came to my mind, he probably has a herniated disc, L4, L5, or L5S1.
Yeah. So we're talking more about what, sciatica?
Sciatica, yes.
So that's the spine. So what we're really talking about is the nerves coming out of the spine, the lower part of the spine, and being encroached on. You may have arthritis in that lower spine, and it's being that nerve is being encroached on as it comes out of the spine. And then you feel it distally, feel it in your thighs, feel it in your calves, feel it in your legs, and that's a possibility.
Especially if it's at the back rather than the front, because of the path of the nerve from the lumbosacral spine on down to the foot.
Right. Dr. Clark, can you help us out any to expand?
Well, I think usually if it's a vascular problem, especially an arterial problem, walking actually would exacerbate it. So the increased activity would cause increased demand. And if there's inadequate blood flow, as we've heard before, with the heart, you'll get symptoms. The symptoms are dependent on where the blockage is, could be thigh or calf cramping. But walking would exacerbate it actually, not make it better.
Right. So if it's vascular, if it's the fact that the legs are not getting enough blood to the lower part of the legs or to the calves or the thighs, if you walk, it'll make the pain worse.
Right.
Okay, and right, all righty. So trying to narrow down exactly what is occurring to this person is more likely, and we can't say exactly what's occurring, but it's more likely that it's the back and arthritis and dealing with the nerves that's coming out and the blood supply coming out, going down. I mean, the nerves going down to the lower extremities, not the blood supply. All righty.
Dr. Bay, if I can also add something else to think about in somebody who may have cramps in the lower extremities, and depending on its distribution, if there's like a tingling nature to this, if there's an underlying history of diabetes, could this be some sort of a diabetic neuropathy? But then also sometimes what I also could see is a B12 deficiency. So maybe even for this person who's suffering from this, getting blood work as well, and making sure there's not an underlying anemia, anything else there that could be a contributing factor.
Excellent.
What about medication? This kind of symptom as a result of certain medications.
Yeah, I'm not sure if it's isolated just to the lower extremities, but it's a possibility. Dr. Clark, do you think that's a possibility?
Can't think of any medication that will do that.
All righty, definitely. Let's go into another question. It says, what device can be given to, and this is a 48-year-old man who had, I think they said had an attack. Hold on.
Had a heart attack. I think it's a
heart attack. I gather it says it's a heart attack. And he's 43 with 4 stents. Dr. Atherley, this come under your category.
Okay. One question would be, how long ago did he have the heart attack? Because the medications given may vary according to the duration since the heart attack. But let me just mention then the immediate medication, immediate approach. If he had 4 stents in place, that is significant. It could be 4 stents in one artery or several arteries which were stented, understanding that there are three major, although they're considered initially two, one on the left and one on the right. But the two branches of the artery on the left are so significant that in their own right, they're considered separate arteries. So we talk about blockage of the artery on the right or two on the left generally. Now, if he had 4 stents, it means that he had more than one stent in a specific or more than one specific artery. And that's significant. Having had a heart attack and having had multiple stents, the question is whether at the time of the stenting, all of the blockages were fixed and there were no more, or were there some blockages which could not be fixed or which were not severe enough to be fixed, but one should keep an eye on them because of the potential for progression in the future to reach a stage where they may need to be fixed. So there are several questions to be answered here. In the immediacy after the performance of the stents and after the heart attack, there is a certain gamut of medications which need to be given and to be followed. Number 1, we give cholesterol-lowering medication, so that even though the patient may feel or may have no documentation of high cholesterol, we think it advisable, having traumatized those arteries with our stents, etc., or the patient having had a heart attack, we feel that it is advisable that these patients should be on cholesterol-lowering medication, period. And the specific kind is statin, torvastatin, simvastatin, etc., etc. So that's one. Another is because we want to limit the work the heart is doing. The heart may have had a heart attack, it may have less capacity to function as strongly as before. We give the patient beta blockers. There are a variety of these, but one of them should be given to the patient after a heart attack. The patient will have had blockage of arteries and, in fact, is predisposed to have blockage of the stent. Therefore, anti-blockage medication, if you will, that is, because we recognize that platelets, those components of the blood, are among the first to clump together and form new blockages, new total obstructions of the arteries or of the stents. And because we know that stents may be particularly predisposed to have clots forming in them, we routinely give our patients who've had stents 2 medications of that same class, aspirin and one similar other medication, Brilinta, Plavix, etc., so that these antiplatelet agents can help to prevent clots from forming in the stents. Newly placed stents are at certainly increased risk for having these blockages. Now, after varying periods, our traditional period has been 1 year, but many studies, especially coming out of Europe, have suggested that there's no need to continue on 2 of these antiplatelet agents for more than 3 months, for example. But traditionally, we have given them for up to 1 year, where the patient remains on aspirin and one of the other potent antiplatelet agents. But after 1 year, they may stop the second one and continue for life on aspirin. So what I would advise this patient is, depending upon the time at which he had his stents placed after the myocardial infarction, continue for 1 year on so-called dual or double antiplatelet agents. At the end of 1 year, he's free to have one of them stopped. Now, there are many patients who prefer to continue and not stop because they have no side effects secondary to these antiplatelet agents. And there is a band of evidence which suggests some benefit, even after 1 year, that I allow my patients to continue beyond 1 year under some circumstances, but mandatorily 1 year, according to our current guidelines. And the other medications that I mentioned should also be continued. Mm-hmm. In terms of what other aspects I'd like to recommend to him, certainly, I'm sure that without my telling that individual, he knows a healthy lifestyle is important. Exercise, achieve ideal body weight, proper dieting, watch the cholesterol intake, etc., etc., etc. Control blood pressure, control diabetes. These should go without saying as important aspects of prevention. Now, we did mention, I think, sporty, something to do with sports. Is he concerned about activity and sports? I would suggest that it depends on how long ago the acute myocardial infarction or the heart attack occurred, he may be allowed to gradually increase back to normal physical activity. And depending upon the extent of the damage, I may or may not allow him to go back to high levels of activity, but certainly normal activity would be recommended. By the way, I want to mention one thing that we thought of in one of the previous questions, and that was this patient who had commotio cordis, that sudden death experience, whether he could play again or not. This occurred in a highly competitive sportsman, and I myself feel a little concerned about letting him go back, but I do know that very clearly because it occurred under such a very specific set of circumstances, and because the hearts are generally not damaged, and it's not a diseased heart that gives rise to the commotio cordis, that is the episode of sudden death that this young football player occurred, that they're in fact allowed to go back to active sport. And there was one of the European soccer players who had this occur, and who within a short period of time was back to competitive sports, representing his club in this country in soccer. So yes, because there's no underlying damage in those circumstances, unlike heart attacks, that patients may be allowed to go back to vigorous activity.
Yeah, in fact, he played in a game this
Anthony, a great
afternoon.
sportsman.
He has a pacemaker put in. Went back and played for Denmark and played in the World Cup and played for Man United today.
Yeah.
So it's always fascinating to me that, you know, these high impact sports with players with cardiac issues can actually return to that level of performance.
Excellent. Excellent.
Remember that is only one of a very rare instances of having sudden cardiac death or sudden cardiac arrest.
Right.
The others I'd be much more concerned about. In this particular instance, there's usually no underlying heart disease, no bruising of the heart muscle, etc., no abnormalities of the blood flow. And if these patients are tested and these are all perfectly fine, well, it's just one of those things where that blow occurred at the wrong time, that 10 to 20 millisecond window of opportunity where it occurred at the wrong time, was delivered with enough force to bring about this. And the chances are that it will not happen again, especially if there's good chest protection. So that's fine.
I see a question about
TVCs,
TVCs, and Omar is going to highlight that question. But
Was
there's
that?
also a second player who went into early retirement because of some dysrhythmia, who is now contemplating returning to his club at a higher level. So, you know.
All righty. Let me do this. I have some other mediums here, and some questions are coming in via those mediums. Dr. Cunningham, there's a question that came in very good for you. We're talking about as far as, and it affects the eyes, the high blood pressure, the diabetes, but also blood flow. And blood flow coming, if it decreases to other organs, does blood flow decreasing throughout the body affect the eyes? And what they also wanted to know was, does that increase the chance that diabetes and hypertension is going to affect the eye as well?
Yes, let me break that down. Of course, as our other speakers have said, the blood vessels, the blood flow to the heart, to the eyes is critical. It's critical. Without the proper blood flow, there's no circulation, there's no aqueous production. Diabetes is a major concern of the retina health. It has knocked down quite a bit of vision throughout the decades. Although diabetic retinopathy, I don't have my stats, has decreased overall. The internists and the people are doing very well. We're taking care of diabetic changes at a much better rate. Diabetic retinopathy is still there. I don't know the prevalence. I'd say it's 60% of all diabetics have some type of retinopathy, but it used to be 80, 70, 80% when we trained 30 years ago, 40 years ago. Hypertension, again, causes pressure throughout the body, throughout the eye. It isn't that severe unless the person is really, really out of control. We don't see papilledema often. ICU patients, yes. We don't see vitreous hemorrhages or ruptured globes from uncontrolled blood pressure. But that macula is very vulnerable to the back of the eye. The center vision part of the eye, called the macula, is very, very, very sensitive to blood flow, as well as vision, as well as light source. So diabetes, hypertension are really vision changers. Besides age, most people get problems with their vision simply due to age. It's nothing wrong. Glasses can pick that up, can help it out. But the other systemic diseases, as you all know, as we know, really, really knock down people's visual health. So the bottom line, as we were saying, please, please, please control your blood pressure, your cholesterol, your diabetes, and it has made a significant change over the years, over the decades. The diabetic retinopathy is not quite as pervasive or present as it had been 2-3 decades ago.
All right.
So Dr.
yeah,
Cunningham, I'm
Patrick,
picking
yes.
on you.
Please.
Yeah, so oftentimes in my family, hypertension tend to run big in some of my family, and
All our families.
some of them, they kind of take it for granted. So to highlight some of the consequences, I often try to make things as graphic as possible. And with respect to vision, and tell me if I'm right or wrong, or if I'm misleading them, I said to them, the most sensitive area of the eye have what we call one single vessel going through it. And unlike other places where you develop collaterals, right? So I guess even in the heart, if the progression is slow enough and you get a slow obstruction on the left side, you could get maybe some
compensation,
small vessel from the right side compensating to help out the left side. We call it collaterals. But the eye, I believe, is one of those organs that has a single vessel going to the retina, and there's no collaterals going to it, right? So I try to make it as graphic for them to understand that you messed this up, it's over.
Right, you've hit the nail on the head. That carotid artery feeds the back of the retina. Now, once it's in the eye, it does branch out, and you have many contributaries. So the eye, like the other organs, try to compensate. We can have blood vessel blockage, vein occlusions, artery occlusions, but the collaterals do try to compensate and fight restoring the health of the eye. But one vessel to the retina, one nerve between the retina and the brain is all we get, and we protect that with everything we can in terms of pressure and meds. Your graphic description is good. It kind of scares people, but there's not much we can do. God gave us one retina artery, central retina artery, close to the optic nerve. So those guys are working together in the same vicinity. Keep the graphics going.
Dr. Cunningham,
Yes, sir.
what would be the most common reason for retinal hemorrhages?
That's a good question. One of the top reasons is the diabetic retinopathy, retinal hemorrhages. There are different types of retinal hemorrhages. The vein can get clogged up. The artery occlusion is less, but retinal hemorrhages, sickle cell can do it. Lupus is rare, but it's on the list as well. But the diabetic has a higher percentage, don't know the numbers, of small retinal hemorrhages, large, I guess you asked about vitreous hemorrhage. Did you say vitreous hemorrhage or retinal hemorrhages?
Retinal.
Retinal. And then it can spill into the vitreous, and then it's like looking through a cloud. You can't see anything because the whole vitreous is foggy.
Okay, Bobby, let me do this.
Hit it.
Explain some of you're using terms that are great for us, but where is the retina? What is a vitreous?
I'm sorry.
Give us some understanding of what you're talking about here, brother.
Let me try to break it down. The eye is shaped like a balloon.
Okay.
You're looking straight ahead at the balloon. The back layer of the balloon of the eye is the retina. That's where the blood vessels come in. That's where the optic nerve comes in. I see what you're saying.
Right.
Inside that balloon should be clear air and fluid that's clear. Mm-hmm. If the back layer of that balloon bursts or blood vessels get clogged, then the inside of that balloon becomes cloudy and just can't see through it. Sometimes you can see through it, but it depends on which blood vessels break. Mm-hmm. The retina is one of the most important parts of the eye. Yes, the cataract and the cornea, but if your retina is in trouble, generally your retinal health, your visual health will suffer. Mm-hmm. Luckily these days, with the way technology and the retina medications have advanced, a lot of people don't suffer as long or as debilitated with retinal hemorrhages, but it needs attention, often more than what the generalists can do. They're getting injections, they're getting surgery quicker, more quickly. So the back layer of the eye is most important.
Okay, excellent, excellent. And some of the things that would cause this hemorrhage are hypertension
High blood
and,
pressure
and
and
diabetes.
diabetes is top tier. Diabetes is top tier. See it in lupus, you see it in cholesterol diseases, but the diabetic is
That's the
very
big
top. Yeah,
All right, all righty. Thank you. That was excellent, man.
you all know
Doc-
that. I hope we can break it down a little more next time around.
all right, we will. You're just getting started, man. Don't worry about it. We're gonna pick on you a lot.
You better. You better.
Dr. Ali, there's a question that just came in. Please, it says, can Dr. Ali please explain what diverticulitis is? I love spicy food, but can eating it aggravate the situation? Are there any precautions or dietary changes I should take with this condition?
So that's a very good question. And diverticulitis is a very common thing that can occur.
Hi, Margaret.
And
Bobby, can you put yourself on mute? Thank you.
So I guess let's step back and let's talk a little bit about what diverticulitis is and how it can form, right? So diverticulitis is inflammation of a diverticula. Okay, a diverticula is a little pocket that can form in the colon. It can form actually anywhere in the GI tract, esophagus, stomach. We could see it in the small intestines, but very commonly we could see diverticula develop in the colon. The condition where these little pockets form in the colon, and it could be more than one, is called diverticulosis. Okay, diverticulosis can occur in over 50% of people over the age of 50. So it's extremely common. And it develops because as we age, as our colon ages, the colonic integrity changes as well. And these little pockets develop. And for most people, you don't feel it. You don't have any symptoms related to this. And I oftentimes, at the time of a colonoscopy, will diagnose somebody or tell them, hey, I found a few little pockets, and this is called diverticulosis. Now, diverticulosis is common, but there are a couple of complications that can develop with diverticulosis. One of those complications is when one of those little pockets, one of the diverticula, the singular of diverticula, becomes infected. And that is called diverticulitis, infection of the diverticula. Kind of, when we add itis at the end, appendicitis, cholecystitis. Appendicitis is when you have inflammation of the appendix. Gastritis, inflammation of the stomach. It's the Latin term for inflammation. So diverticulitis is essentially inflammation of that diverticula. And when the symptom that you can develop from that is pain. And particularly the most common place that we could see pain is pain in the left lower part of the abdomen. And the reason for that is because one of the most common places that diverticula can develop is in what we call the sigmoid colon, which is the part of the colon that's lower down. It can occur anywhere, but that is the most common place that we can see it, and that's the most common place that diverticulitis can develop, although it can develop anywhere through the colon. Now, diverticulitis can present with pain. Sometimes it could present with a tenderness where you push down on the stomach and it can hurt, fevers, chills, and oftentimes this pain may warrant somebody to go into an urgent care or seek more urgent medical care. And the way it's diagnosed typically is by imaging or by a CAT scan. And on a CAT scan, if we see that there's inflammation surrounding a diverticula, one of those little pockets, that's how we diagnose diverticulitis. And, a lot of times pain, we think about when pain could be severe, it can be a case of diverticulitis, but not always. So it's important to kind of gauge that pain if it's something that's new. For somebody who may have had diverticulitis in the past, there is a chance of recurrence of it occurring again. So if you get it once, you got more than a 30% chance of it getting it, or a 50% chance of getting it the second time. And then if you get it a second time, you get an even higher chance of getting it a third time or a fourth time. Now, how we typically manage this is with, traditionally with antibiotics. Sometimes we can get away with not treating antibiotics, and that's due to some more recent studies showing that we can try to conservatively manage it. But in the cases where it's creating an infection that is creating a more systemic problem, significant pain, a course of antibiotics usually can do the trick to help treat this. But in the setting of a recurrence, where it comes back a second time, a third time, a fourth time, in those scenarios, the treatment becomes a little bit more personalized, and it may involve us saying, well, I may need to refer you to my surgical colleague to remove the part that may continue to get infected. But we try to avoid that at every cost and every step of the way. It's not a situation where you get this once and you get referred to a surgeon. We really individualize that and prevent that at all costs. Now, one of the ways that we can help to prevent diverticulitis and minimize any complications from diverticulosis. So I mentioned the one complication is infection, diverticulitis. The second is very, very rarely they can even bleed. Okay. And that's called a diverticular bleed. Those are the two things that we can see. And again, they occur very, very less common, very rarely. They're rare. Now, in the setting of how we can prevent a complication, we recommend fiber. Fiber is the colon's best friend. And fiber can be taken in by diet. That's the primary way, fruits, vegetables. For folks who may have a difficult time eating high fiber, I often recommend a fiber supplement, something like Metamucil or Benefiber or Citrusal, some sort of a fiber supplement that can potentially help in guiding, or at least in bulking up the amount of fiber that goes to the colon. Ideally, you want to get between 25 and 30 grams of fiber a day when somebody has diverticulosis. But in general, it's also good for colonic health. It's good for your microbiome. It's good for bowel regularity. And high fiber also is good in preventing issues like colon cancer and things of that nature as well.
Excellent, excellent.
Doctor, what foods can trigger diverticulitis? Certain foods that we eat?
So it's a very good question. And a lot of times we hear about patients being told, well, avoid things like seeds and nuts. But when we look at the data, really, we don't have a lot of good data that shows that those things truly can cause diverticulitis. So, in general, what I do tell patients is get a good balance of fiber in the food, fiber in general from fruits, vegetables. I don't necessarily tell them avoid seeds, don't eat nuts, because these are foods that are actually very high in fiber. So they can help. And I don't have, in regards to literature and the data, telling us that these things can cause diverticulitis. Now, there was a question about spicy food.
Now, is it not true that when I went to school, that's what they taught us, that since we don't digest these things, little particles will lodge in the.
I'm not sure it's true.
Diverticulum. Is that true?
Nuts and seeds have not been shown to be. I know we tell patients that, but that's not. That hasn't definitively been shown to be.
So there are no studies that were done in terms of that.
Right.
The studies show that there's no data to link seeds, nuts to diverticulitis. So we've actually negated that. And I've kind of, I tell patients now it's okay to have seeds, nuts, because these are foods that are rich in fiber.
Okay.
So we're changing the way we're thinking about this. And this is something that has changed, for over the years. Right. So you're right, though. Before we used to say that all the time, but now we've really moved away from that.
Yeah, another
We're,
component of it is,
we're
you know,
showing our age here, Dr. Court.
I
That's
know,
all right.
right?
I'm still all right. I'm still on top of it, Doc.
Well, it's not
Another
that long ago,
component-
actually.
Yeah, another component to this actually is how we often help patients manage constipation, right? We often say to them, you know, maybe some mineral oil or, foods that are rich in some essential fats, right? Like avocado, but also some of those foods that they say not to eat if you have diverticular disease, like nuts, are also help in lubricating the inner, the lumen of the colon and help with defecation. So it kind of flies in the face of that concept.
Yeah.
Again, I tell
Very
patients, fiber is the colon's best friend. It's the ultimate bowel regulator. When somebody may have constipation, fiber gets them in that middle. When somebody may have diarrhea, fiber gets them
Get
right
them
into
to that middle, right?
Yeah, excellent, excellent. There's another question that just that's come in. We're getting some good questions. What options are available for people with PVCs and a low ejection fraction, 35 to 45, who have had 2 ablations with some lowering of the PVC burden? What about Sotolol, SOTALOL, tongue tie? Only symptoms are palpitations, no swelling, and no shortness of breath, Dr. Athley.
All right. I actually had my hand raised because I was going to ask the question of Dr. Ali, but I'll answer this one first and then go to him.
Oh, okay.
Yeah. Anyway, yes, the question was about PVCs.
Yes,
Right.
PVCs with a low ejection fraction and had 2 ablations in the past.
All right. First of all, what are PVCs? PVCs are premature ventricular complexes or contractions. I mentioned in the past about the orderly beating of the heart, where the chambers are supposed to beat in proper sequence, having been stimulated by the electrical conduction system. PVCs are impulses which arise out of turn. So you may experience these, as mentioned, palpitations, a little fluttering, a little skip beat in the heart, when areas of the heart suddenly beat out of turn before the expected occurrence. In general, there may be annoying little PVCs, blah, blah, but in general, simple, isolated, single PVCs are not considered a serious concern. However, more importantly is, what are the underlying factors that give rise to these PVCs, and what are the associated features? If, for example, the PVCs are telling us that you have insufficiency of the blood supply and they're occurring in association with exertion, occurring in association with ischemia or insufficiency of the blood supply to the heart muscle, then they may tell us we've got to look for the underlying causes and take care of them. If they're occurring in the situation of impaired left ventricular contraction, and here I think the questioner asked and did in fact give ejection fractions. Again, just so we can explain what the ejection fraction means. When the heart contracts, it usually squeezes out between 55 and 70% of the blood that fills it. In other words, you look at the amount of blood filling during the relaxation phase of the heart muscle, the ventricle we're talking about, those powerful pumping chambers, and then look and see how much is squeezed out, so that at the end of the squeezing process called systole, at the end of systole, we look to see how much is left. And nobody squeezes out 100% of the blood that's in the heart. That does not happen. But you squeeze out a varying proportion between 55 and, depends on how it's measured, by echocardiogram, 55 to 70%. But other parameters may show 50 to 70 or so. So when this the questionnaire mentions that his ejection fraction is 35 to 45, what he's saying is that there is impairment of the strength and contraction of the heart muscle. And this now moves the PVCs into more importance. They're not just PVCs, but they're PVCs occurring in the setting of a lower ejection fraction. Now, we have done studies, let me just say that in general, if there's need to treat the PVCs because we're concerned that they're in a setting which can give rise to more repetitive firing and sometimes dysynchronized firing, ventricular fibrillation, where they can eventually lead to rapid heartbeats, sustained, not individual beats as we mentioned PVCs, but sustained, many of them coming one after another without a pause. That's called ventricular tachycardia, or dysynchronized, going from race to total malfunction of the heart muscle, electrical chaos. where there is then ventricular fibrillation. If we're worried about any of these occurring, then we may see the need to treat these PVCs earlier. And we can treat with medication, of course. There are some medications that we use, and the medications might be used to treat the underlying heart situation and incidentally also treat the PVCs. Now, he mentioned a few terms, ablation. That is where one can determine pathways for frequent, say, sustained rhythms with these irregular heartbeats. One may ablate or put a little device in and electrically burn away the area where they originate or the pathway they follow, so that they do not continue to cause these dangerous rhythms. Again, simple PVCs, no problem. Sustained one after another could be a problem. And total desynchrony is a big problem. So you don't want to get to those stages. So that's one method of electrically treating. Another is that if these are warning us that there's an underlying setting and whether or not you see PVCs, if your ejection fraction, the term he used, which demonstrates the strength of the heart muscle, if you show that the heart is weak, regardless of the cause of the weak heart, whether it's weak from previous heart attacks, whether it's weak because your blood pressure was uncontrolled, whether it's weak for other reasons, if your heart muscle is below a certain strength, then it is warning us that you're predisposed to having those dangerous rhythms where the heart can beat rapidly or chaotically, and in which case, what you may feel is not just the palpitations, but you may pass out faint or worse, sudden death. So under those circumstances where the PVCs are threatening and the ejection fraction or the strength of the heart muscle is so low that it becomes dangerous, under those circumstances, we can implant an electrical device in you called an ICD, automatic idiopathic converter, cardiovascular converter. And this defibrillator, what it can do is detect what your heart is doing in terms of its rhythm. And if you indeed start to have those erratic or irregular beats and they're occurring, sustained or one after another without pausing, then it can detect that and the variety of means by which it may stimulate the heart muscle, and ultimately it may even deliver a shock to the heart muscle from the inside to get rid of those rapid heartbeats, the defibrillator. So these are some of the potential things that can be done. I will say that with the ejection fraction between 35 and 45, it does not appear mandatory because 35 is the cutoff point. Usually below 35, the strength of the heart, would be the number at which you'd be forced into considering that. So he still may be at the status of medication to control his symptoms, and it may not be mandated that he have that. Now, of course, if he has symptoms that relate or suggest, then he may require electrophysiologic testing, that is, special electrical testing by a specialist, a subspecialist in cardiology, who can measure the electrical activity of the heart and determine whether or not there's a need for those extraordinary measures. I presume he's had that because if mentioned ablation, it would imply that they already did an electrical test on the heart. So those are some of the possibilities for future treatment of the, not just the PVCs, but of the consequences of PVCs.
Dr. Athey, if I may just ask you real quickly while you're on the topic of PVCs. So I would imagine an ablation is the opposite of putting in a defibrillator. But can you differentiate for us the difference between a pacemaker and a defibrillator?
Well, they may be different, or in fact, a pacemaker may be included in the same. The defibrillator, the basic function of that is to determine if there are the rapid heartbeats, which if considered a danger because they are sustained over a long enough period, etc., rapid heartbeats, which may be considered an immediate danger and may require to get rid of them, to shock the heart, to get rid of them. Or sometimes, short of that, they may do rapid pacing, rapidly put out impulses to try to capture the heartbeat and restore it back to a normal, regular heartbeat. So that is to deal with rapid heartbeats or the complicated, rapid, dysynchronized beating of the heart. On the other hand, the pacemaker generally is used for slow heartbeats. If your heart beats too slowly, it is possible that you could have symptoms which may be dangerous. You could faint, you could pass out, you could have a number of different diseases which may be associated with slow heart beating, heart blocks of varying kinds, second degree heart blocks, third degree or complete heart blocks, etc. But the bottom line with those is that if the heart rate is slow enough that the heart is not putting out blood at enough of a pace to properly sustain function of the rest of the body, to properly fulfill the needs of the brain, etc., that one could faint, pass out, or even worse. In which case, we put a device which takes care of slow heartbeats. That's the opposite of the defibrillator, to take care of the slow heartbeats, and that's a pacemaker, which can detect if and when the heart is going too slowly and can pace the heart to beat at a faster rate. Now, what one normally would have is a pacing device, which is the brains of the device placed under the shoulder, under the collarbone, and that is connected to wires, which wires then go through the veins back towards the heart and may be put in certain specific chambers of the heart. So they're detecting the activity of the heart electrically. When slow heart rates are detected from the inside, then they relay this information back through these wires to the pulse generator or the pacemaker device and tell it, hey, the heart is going a little slowly, speed it up. So that device only then puts out impulses, electrical impulses, to speed the heart rate up. So in the one instance, we have the pacemaker, which helps to control the rate of the heart when it goes too slowly. You drop below a certain level, up starts to beat your heart at a faster rate. On the other hand, the defibrillator does the opposite. If your heart is erratically beating too fast, then it may shock you, so that we can then have a controlled rate at a better level. Remember, however, they're not necessarily in exclusion, and that many of the defibrillator devices have a built-in pacing device, so that if you shock the heart because it was going too fast, and unfortunately, it goes too slowly immediately after you shock, then that device can also pace your heart to get a more appropriate heart rate going.
Excellent. Excellent. Dr.
Trevor,
Ford.
in this patient with an ejection fraction of 35, would a medication like Entresto be indicated? And if not, what would be an indication for Entresto?
Oh, absolutely. Absolutely. There is we were discussing only the electrical phenomena, of course, but I agree with you entirely. There is a problem. The heart is not beating strongly enough. It has systolic failure. And therefore, the impetus is on us to try to improve that. Now, in the past, we've used many drugs to help improve the strength of the heart, with minimal success in terms of the degree of improvement of the strength. But there are a few that have come out now, and Entresto is the leading one, is one of my favorite ones. Entresto is one of those medications which has not only been shown to be associated with increased ejection fraction, but the consequences of heart failure, et cetera, are diminished, so that it improves the longevity of the patient, as well as diminishing the consequences of that low ejection fraction, heart failure. So yes, there are a number of medications which can be used to improve the overall function of the heart and do not directly affect that the PVCs, only indirectly.
So this is where the conversation develops, right? You know, I don't profess to be an expert in hearts. I break them, I don't fix them, okay? So here's the issue.
Why is that?
So, here's the issue. With respect to medication, is there a mechanism to distinguish why the ejection fraction is so low? Is it a situation where the PVCs are so frequent that you have a poor ventricular response, in the setting that you don't have enough time for the ventricle to fill, hence it pumps less blood, versus a weakened heart muscle causing an irregular electrical impulse?
Good point. Well, when the heart muscle is weakened, we do not often assume or prove that single isolated PVCs can cause that. In fact, after the PVC, there's a so-called compensatory pause. I don't want to become too technical, but after that beat is out of turn, there's a longer pause, giving restoration of filling of the ventricle or the heart muscle, so that the next beat is often stronger after a PVC. So the isolated PVCs do not give rise to those low ejection fractions. The ejection fraction certainly could fall during a sustained episode where there are multiple of those kinds of beats occurring one after another. But the point I'm reading into what you're saying is, yes, it may be important to go for the underlying cause, to try to take care of the underlying weak heart. I would not assume necessarily the PVCs to be causing it, but to be the consequence of it, and take care of the underlying weak heart as per the question of Dr. Cord. So yes, important that we look at the mechanical effects and relate them to these electrical phenomena which we observe.
Excellent. Excellent. Any more questions? All right, Dr.
I did
Atherley,
have a
I know
question.
we're almost at the end of our program. You had a question for Dr. Ali, though.
Yes, I just wanted to ask, is there or what is the association between diverticulosis and colon cancer? Is there a stated relationship or is it
It's a
overstated?
very good question. Now, there is not an association that we know between diverticulosis and colon cancer. However, whenever somebody develops diverticulitis, an initial case of diverticulitis, one of the questions we have to ask is why. We assume that maybe a piece of stool gets stuck in one of those little pockets and it creates a problem. But we really want to make sure that we confirm and exclude any sort of a cancer. So whenever there's somebody who does present with an initial case of diverticulitis, the standard of care and the recommendation is for a colonoscopy for direct visualization and to exclude that that's not a polyp or something else that you're seeing that's causing that issue with the pain and the presentation that that person may have had. Now, and this kind of leads into a very important piece. So colon cancer screening, colon cancer can affect people in many different ways. And diverticulitis, the presentation of pain, tenderness in the belly, it can mimic that. So we need to make sure that there is not a cancer there. But you would want to do at least 6 to 8 weeks after the diverticulitis or that infection is resolved.
Yeah, and there was a question also about polyps, and the more polyps, the more likely cancer. I know polyps is different than, but since you brought it up, can you just address that before we end?
Absolutely. And colon cancer is a big topic that I hope that we would maybe on our next session we can touch more about this, because I could talk about it for a long time.
Oh, we will.
Here can. Jesse, especially with kind of what we're seeing in the disparities of colon cancer screening. But I can tell you that polyps are found in our literature. We see that polyps are, at least it's stated, about 30 to 50% of the time when somebody undergoes a routine colonoscopy, we will find a polyp. What is a polyp? Polyps are little growths. They're little growths that start out in the colon, almost like I akin it to a mole on the skin. And we don't know if every little polyp is going to turn into a cancer. But we also, when we do a colonoscopy, we're doing it once, right? We're doing it once over every few years, or maybe even every 10 years. So whenever we see a polyp, we got to take it out. Whenever there is a polyp there, it could be what we call a precancerous polyp, also known as a tubular adenoma or a serrated adenoma. These are little growths that over time have that potential to grow into a colon cancer. It can take years. It's a very, very slow process. Now, a colonoscopy, the beauty of a colonoscopy is that we can screen people for colon cancer, which is the third most common cancer in men and women. Second leading cause of death from a cancer. So it's very prevalent, but it's preventable by a colonoscopy because we can look for it, but also we could look for these polyps and we can remove them. And the scary part is that I find polyps in 30 to 50% of people that I do a colonoscopy on routinely. You do not need to have any symptoms to have a polyp. None. It's only until it grows too big, it causes a blockage. And that can it can have a presentation similar to diverticulitis. And it's why we want to make sure we're doing colon cancer screening for patients who present. So, and it doesn't matter of age. The age, though, is 45 for men and women.
Excellent. Excellent. Well, go ahead, Dr. Court. The last question is Dr. Court.
Last one, yes. Cologuard, doctor.
Say that again, Dr.
Dr.
Court.
Ali.
Cologuard.
Cologuard.
So that's a great question. So Cologuard is one of the modalities that we have to screen for colon cancer. Colon cancer screening, the gold standard test is a colonoscopy because we look for cancer, but also if we see a polyp, I can remove it right then and there, negating a problem. However, we're only screening 20% of our population. We can't get enough people in for screening. And why is that? One, people are unaware. Two, it's an invasive test. It's a test that requires a bowel preparation. People have to take time off from work. But So an alternative to try to get more people to screen so we can tap into this population is a Cologuard test. A Cologuard test will detect a cancer or an advanced polyp, but it's not looking at these little polyps that I could potentially take out. However, if somebody is offering if somebody would rather take a Cologuard than a colonoscopy, I tell them go for it, because we just need to get more people screened. My preference is a colonoscopy.
I agree with you, doctor.
All
Because
right,
if you do
Omar, let me
Cologuard, you
stress you
still
a
have to
little
do the
bit.
colonoscopy anyway, right?
If it's positive, you
Yeah,
have
yes,
to get a
have to do it
colonoscopy, and there's a 13% false positive rate on a Cologuard.
Cologuard, yes.
All right, Dr. Bay, let me stress you a little bit. I know time is of the essence, but with respect to screening for cancer, let me just remind everyone,
Okay.
January is Cervical Cancer Awareness Month. And unlike colonoscopy, no preparation is required. As long as you meet the standards. If you're 21 years or older, if you have history of any kind of human papillomavirus related disease, if you engage in any high risk sexual behavior, please get screened for colon cancer. Like colon cancer, cervical cancer is one of those cancers that we can identify a pre-invasive lesion, like a pre-invasive polyp in colon cancer. That pre-invasive lesion can be treated in a relatively innocuous, non-invasive way, like removing a polyp from the colon. So please, January, we should be screening patients all year round, but just to highlight that we still see 12,000, 15,000 new cases of cervical cancer a year. And this is in spite of having a very effective vaccine.
Excellent. Excellent. All righty. Well, this was an excellent webinar. You guys got me hopping and I'm loving it. All righty. So we're going to close out right now because the time is gone and it went fast. Number one, I'd like to thank OBHealthy. I just can't thank them enough for allowing us to bring this webinar to you. Go to their website, go to their app, download it, check them out. They talk about health and wellness. They talk about weight loss. It's just a great, great presentation that they do, and they're helping so many people around the world. Number one. Number two, remember, and please share this, that our webinar is every second Saturday at 1 o'clock. Come on, be a part of it. Don't miss it. And if you want to check out our old webinars, just go to OBHealthy's website, scroll to the bottom of the page, hit the YouTube sign, and check out the old webinars. Not the old webinars, but the prior webinars. I shouldn't say old because they're not old, they're just prior. And subscribe so we can continue to bring this to you via YouTube. Remember, it's caring and sharing. Let everyone else know about it. Your friends, your family, church members. You know, we're people that communicate, and it's caring and sharing, and that's what it's all about. The most important thing, and I'm always going to say this, you're going to get tired of me saying it, but please do not share or please do not change any aspect of your medical care until you consult your physician. Only your doctor can truly take care of you appropriately. All righty. And I just want to say thank you for being a part of it. Thank you for the physicians that come on and give up their time. It's so important what we do. And I look forward to seeing you next month. So until next month, I want to say peace and take it easy out there. We will be here at 1 o'clock that second Saturday. Thank you. All right. Peace, everyone.
Bye.